in the United States, we first started to see, hear news from our colleagues in Washington State about the COVID-19 surge after there was a breakout in one of the nursing homes. And then towards the middle to late part of February and early March is when we started to hear about the surge up in the Northeast, in the New York, New Jersey area, and up in Boston. And we paid heed to it. We also were learning about the extraneous circumstances that our colleagues in Italy were facing, and the way that their healthcare system was overwhelmed, and instituted policies where we started to do medical distancing, for patients who could get less frequent infusion appointments. We would be changing them from weekly to every 2 weeks, every 2 weeks to every 4 weeks. We tried to change to oral regimen in selected patients. We tried to delay bisphosphonate or denosumab infusions, to avoid patients coming into the healthcare setting, and started to use the virtual platform more often to engage patients. We also changed to a team A, B, C model with 2 weeks on-site, 2 weeks off-site, kind of a format, following the lead from our Italian colleagues and the Chinese colleagues, and made some of those adjustments in our practice so that we can, if we were to get overwhelmingly high number of COVID-19 disease patients in our hospital, we would be able to manage them effectively. We also try to delay stem cell transplants and CAR-Ts where we could possibly do so, because even though we are a 1,000-bed hospital, if there were going to be a significant number of COVID-19 patients requiring care, the priorities will obviously change, and it would not be the perfect time for our patients who are already immunocompromised to be in the hospital. It also impacted our ability to offer clinical trials to patients because of going to this team ABC model, which applied not just to doctors but also to nurses in the clinical trials office. So we were working with less staff than usual. So we offered standard of care treatments to patients where possible. For the relapse refractory patients, we obviously we're looking for good clinical trial options for those patients where we could. Some of our struggles early on were with inability to actually provide COVID-19 testing. Our healthcare system also set up drive-through testing, as well as created a virtual COVID-19 hospital using that virtual platform. So patients who had less frequent or mild to moderate symptoms, we were managing them at home through a virtual hospital model, where doctors and nurses would be able to check on those patients or send people in to check on them periodically, depending on what kind of symptoms they had, while managing them remotely. So we made a lot of these different adjustments. It was also a fascinating time to see, how ill-prepared our healthcare system in general was. We did not have adequate, PPE initially, and eventually a lot of innovative things were done to get adequate PPE for all healthcare workers so we could work in a safe environment. I actually have to say from on that end, our healthcare system, Atrium Health, and all the colleagues worked really well together, and we were able to overcome a lot of those barriers.